GTG guideline as well as the talk on endometrial hyperplasia. It's an important exam tested topic. Mostly every year questions are asked on this. So it is very important that you all are thorough with it. So we'll start with a quote that in order to do better in your life, you have to dream big and then set goals to achieve that dream and accordingly take action so that you can fulfill all your goals. Now, coming to the topic. So this is a topic from the gynecology module, a very important topic. So endometrial hyperplasia. What causes endometrial hyperplasia? So the causes or the risk factors for endometrial hyperplasia, they revolve around a hormone which is called estrogen. This estrogen, anything which increases the estrogen can result in endometrial hyperplasia. So if the risk factors include if the patient has high BMI. So what happens if the patient is obese or high BMI? In the fatty tissues, the androgens, they get converted to estrogen. So this is something which can result in hyperestrogenic state and in turn result in endometrial hyperplasia. The second thing is anovulation, as in polycystic ovarian syndrome. So what happens if in a normal cycle, what happens? There is estrogen in the follicular phase, and in the luteal phase, the estrogen goes down and the progesterone takes over. However, if a patient is not ovulating, what happens? The estrogen keeps on building up. The follicles keeps on getting recruited and they do not reach a maturity stage to cause ovulation. As a result of which the estrogen in the body increases, and it also results in causing hormonal imbalance, problem in the cycles, and this in turn, because of the hyperestrogenic state, can result in endometrial hyperplasia. Then the other cause could be certain tumors which cause high estrogen. So the most common tumor being granulosa cell tumor, which is an estrogen secreting tumor. So it has a risk of around 40% of developing into endometrial cancer. And the most common type of cancer, if they ask you, or it is 40% risk of endometrial hyperplasia, which in turn also increases the risk of endometrial cancer. And the most common cancer which has been associated with granulosa cell tumor is endometrioid type because of the hyperestrogenic state. Then other things include when you're taking, this was the body producing more estrogen. Now, if the patient is taking estrogen from outside, so it could be in the form of hormone replacement therapy in a menopausal patient, that increases the risk of endometrial hyperplasia. The other thing is if a patient is on tamoxifen. So tamoxifen, it is again a SERM which increases the estrogen. Estrogenic action on the endometrium is high. So again, this is an important cause of endometrial hyperplasia. Then, what are the types of endometrial hyperplasia and what is their risk of developing into cancer? So now endometrial hyperplasia, like the previous definition where they had divided as simple, complex, now that this has changed. Now it is classified as endometrial hyperplasia with atypia and atypical endometrial hyperplasia. So broadly, there are only two categories, with atypia and without atypia. So the one endometrial hyperplasia without atypia, the chances of developing cancer is quite less. It is around less than 5%. And if we talk about endometrial hyperplasia with atypia, the risk is around 27%. The treatment for endometrial hyperplasia with atypia is actually removing the womb or doing either laparoscopic abdominal hysterectomy or a total abdominal hysterectomy because of very high risk of cancer, obviously. And suppose you're doing a surgery for an atypical hyperplasia. So it has been found that in some cases, because how are you diagnosing this hyperplasia is by biopsy. It could be a hysteroscopy or a blind biopsy. So where you're not sampling the entire part of the uterus. So some areas might be missed. So it has been seen that in around 43% patients who undergo hysterectomy for atypical hyperplasia per se, when you send the sample for histopathology, there is an occult cancer lying in. Some of these might not receive additional treatment. It depends upon the staging. Then in case such a report comes, we'll have to do a complete staging for these patients. So they may or may not require additional treatment. So whenever we are doing surgery for atypical hyperplasia, we always have to take consent for need for additional treatment later. And the risk of occult cancer lung cancer, which is as high as 43%. So this was about it. Now coming over to management. So if we talk about management of endometrial hyperplasia, first we'll start with without atypia. So without atypia, because the risk of cancer is much less in these patients, so you can manage them medically. Okay, so the best thing which you can do is give them a Mirena coil or LNG-IUS because it is effective for 5 years. It can be given for patients who have plans of pregnancy or even who, and obviously for obvious reasons, for those who have completed family. For those who have plans of pregnancy, you can put Mirena and then rebiopsy after a period of 6 months with Mirena in situ. And if they have a future plan of pregnancy, then they can, in case there is regression, they can go ahead with it. And if they do not have plan for pregnancy, then you can continue this LNG-IUS for a period of 5 years. The benefit would be, one, it will control the bleeding issues. It will cause regression of the hyperplasia, decrease the chances of endometrial cancer, and also serve as a contraceptive. So it is a very good option for endometrial hyperplasia without atypia. However, some people say that they do not want to go with the LNG-IUS. They do not want any coil to be inserted. So then what options do you have? So here you can give progesterones. So these progesterones, you give a higher dose than a traditional dose of the progesterone. Either you give medroxyprogesterone 10 to 20 milligram per day or norethistron 10 to 15 milligram per day, and this is continuous. You do not wait for a cyclical bleed. This is again very important. You give continuous progesterones, high dose, for a period of 6 months. Why this 6 months? Because after 6 months, you have to check whether there has been any response to these medications that we have given on. Okay. Then, suppose, in what cases of endometrial hyperplasia do you plan to go ahead with hysterectomy? As I told you, the first line is always progesterone. The better would be Mirena. The second option is oral progesterone. But there are certain indications where you go for hysterectomy. What are those? So obviously, hysterectomy, it is done if the patient doesn't want to conserve her fertility. So what happens whenever you are treating this endometrial hyperplasia? You do biopsy again after 6 months to see whether there is regression, because you have to see whether you have to continue the treatment or you can discontinue or not. So you have to do basically 2 biopsies until negative 6 months apart. And after that, you can discharge the patient depending upon what the BMI is. If BMI is more, you continue doing annual biopsy, because then, as I told you, obesity is an independent risk factor for endometrial hyperplasia and cancer. Okay, so now coming over to hysterectomy. So hysterectomy, suppose you've done the biopsy at a period of 6 months and you see any kind of progression to atypical hyperplasia during your follow-up. So then, obviously, then you have to do hysterectomy. Second thing is, you have been following up, you're doing 6 monthly biopsies, but you see that there is no histological regression. Despite you've given 12 months of treatment, there is no regression, it is the same. Then again, and obviously in all hysterectomy, you only do when the patient doesn't want to preserve her fertility. Then the third is, if there is, suppose, in one of the biopsies, you have seen regression, but then even after completing the progesterone treatment, you do another biopsy, there is a relapse. because you cannot continue, especially the oral ones, you cannot continue for longer times because there are risks associated with them. So if there is a relapse after completing progesterone treatment, again, you go ahead with hysterectomy. Or even if you've given the progesterone, the patient is having some bleeding symptoms. So that's another indication. Or if the patient declines to undergo any kind of endometrial surveillance or comply with medical management. So if she doesn't want to go ahead with surveillance and she's completed family and she doesn't want any kind of medical management, so that's again an indication where you go ahead with hysterectomy. Then these questions, I'll just give you 1 minute to type in the comment section what would be the answer to these questions, and then we'll discuss it. I hope all of you are writing in the comment section about the answers. Okay, so coming to the answers. So treatment for endometrial hyperplasia without atypia, as we have discussed, you can give oral maximum up to 6 months, or Mirena coil, which can be retained up to 5 years. Then about the surveillance interval. So surveillance interval, you have to do 6 monthly, and you have to do biopsy 6 monthly until 2 negative. Actually, according to the recent talk, we'll be discussing it later also, that it depends on the BMI. BMI is less, you can, if 2 negative biopsy 6 months apart, you discharge a patient. If the BMI is more, then you continue annual surveillance. And number of biopsies prior to discharge is 2. Now, this is endometrial hyperplasia follow-up. If endometrial hyperplasia without atypia, you have to do 2 consecutive biopsies, should be negative 6 monthly apart until you discharge. Actually, it depends on the BMI, as I was telling you, and the cutoff for the BMI is 35. If it is less than 35, then you can follow this, that is 2 negative biopsies 6 months apart. In case the BMI is more than equal to 35, then you can do after doing 2 negative biopsies 6 months apart, you have to do an annual follow-up, because these patients, they have quite high risk of endometrial hyperplasia and endometrial cancer because of the obesity thing. Now we have completed about endometrial hyperplasia without atypia. Now coming over to atypical hyperplasia. So atypical hyperplasia is, as I told you initially as well, the management is you have to remove the uterus. So, however, this is when the patient has completed family. Now, in a patient who is premenopausal, if you remove the uterus as well as the ovaries, they are at a risk of postmenopausal symptoms. So what you do, you remove the uterus and the tubes and leave the ovaries behind. So for them, if the patient is premenopausal, you have to do total abdominal hysterectomy and bilateral salpingectomy. And why you remove the tubes? Because it has been seen that the ovarian cancer, they arise from the femoral end of the tubes. Now coming over to if it is a postmenopausal patients. So postmenopausal, so we do not need ovaries as well. So you do total abdominal hysterectomy, bilateral salpingo-oophorectomy. And what has no role in atypical endometrial hyperplasia? So there is no benefit from intraoperative frozen section of endometrium or removing the lymph node or endometrial ablation. Actually, endometrial ablation is not recommended at all in any kind of hyperplasia. Why? Because what do you do in endometrial ablation? You burn the endometrium. So once you burn the endometrium, you will not be able to follow up this patient and see whether the hyperplasia has regressed or not. Sometimes, because the endometrial sampling won't be possible after burning the endometrium or doing ablation. So that's not recommended at all. Now, suppose a patient with atypical endometrial hyperplasia, she's not willing for hysterectomy. Then how do you go about? Because she wants to conserve her uterus because she has fertility concerns. So then in those cases, you have to do a biopsy at 3 months, every 3 months, until 2 negative biopsies followed by 6 to 12 monthly. This is if she doesn't have fertility concerns. Okay. If she doesn't have fertility concerns, you can just in hyperplasia, simple hyperplasia or hyperplasia without atypia, I said you have to do 6 monthly biopsy until 2 negative if the BMI is less than 35, otherwise annually after 2 negative biopsy. In this, you have to do if a patient refuses for hysterectomy because you cannot do anything without her consent. So you have to do biopsy every 3 monthly until 2 negative, and once 2 negative, then 6 to 12 months. So it is more frequent than simple hyperplasia. You always have to tell the patient that there is a very high risk of cancer. Now, if the patient wants a fertility, patients with atypical endometrial hyperplasia, they want fertility. Then what you do, you take a biopsy at 3 months, and in case you see that there is some kind of regression or it normalizes, the biopsy reports come out to be normal, then you refer them to, because you do not want them to wait for long, so then you refer them to fertility clinics so that they can go ahead with ART, complete their family fast, and then go ahead with the surgery. And this, like if a patient has fertility concerns, this biopsies, 3 monthly biopsy, you can do only till 1 year. Suppose there is no regression in 1 year also, then you tell them that there is high risk of progression to cancer and it is recommended that they go for hysterectomy. So this was about the management of atypical endometrial hyperplasia. Now, these are certain scenarios. I'll just give you 1 minute to go through it and write the answers in the comment section, and then I'll be discussing about the answers. Okay, I hope all of you have written the answers in the comment section. Now moving on to the answers. So the first scenario, she's 32 years with endometrial hyperplasia without atypia. So what is the management? As I've already told, LNG IUS or oral progesterone, and then you do endometrial hyperplasia. Since she's less than they've not mentioned about the BMI here. So 6 monthly till 2 negative biopsy. In case they would have mentioned the BMI is more than 35, then annually thereafter. Now, the second scenario, she's 30 years, nulliparous with atypical hyperplasia, and she has plans for pregnancy. So, first of all, you have to rule out any kind of cancer because I told you they have around 27% risk of endometrial cancer and around 43% risk of occult cancer after hysterectomy. So, you have to be very sure before giving them a trial of pregnancy that they are free from cancer. So you do formal hysteroscopy and also the tumor markers because there is a 4% risk of ovarian cancer associated. So you do tumor marker CA-125 imaging, TVS MRI. Also, you get an MDT review. And after that, you do a 3-monthly biopsy. And when you get one negative biopsy, you refer them for assisted reproductive clinic. And once the family is complete, you always have to go ahead with TH because she's young. So bilateral salpingectomy here. Then 44-year-old completed family with atypical hyperplasia, it is TH plus bilateral salpingectomy. Then 32-year-old completed family, endometrial hyperplasia without atypia and follow-up biopsy resolved. Then you can just give LNG or IUS, the best thing because she's completed family, so the best option for her would be Mirena for 5 years. Now the last one, 44-year-old completed family with atypical hyperplasia. She started LNG-GIUS, but repeat biopsy shows now atypical hyperplasia. Again, so now you have to counsel her that since it is not regressing and it is atypical, it is best that she go for total abdominal hysterectomy and bilateral salpingectomy because she's premenopausal. Okay. So these are again about the follow-up, questions about the follow-up. I'll again give you 1 minute to go to these questions and write the answers in the comment section, and then we'll go to the Okay. So coming to the answers now. So the first one, she's 32 years with endometrial hyperplasia without atypia, BMI of 32, that is less than 35. So you will follow up with 2 consecutive negative biopsies, 6-month interval. And once both come out to be negative, then you discharge. The second scenario, she is 32 years with endometrial hyperplasia without atypia and the BMI is 35. So here again, since it is without atypia, you have to do initially 2 negative biopsy, 6 months apart. But after that also you cannot leave the patient because the BMI is more here. So you have to do an annual endometrial biopsy thereafter. Then the next scenario, she is 44-year-old atypical hyperplasia on BMI of 20 with a BMI 23. So here you have to do initially 2 biopsies. If she's not willing for hysterectomy, ideal treatment, as I told, is hysterectomy. In case she's not willing for it, then you do it 3 monthly until 2 negative biopsy and then 6 to 12 monthly and review. Then the fourth scenario, she's 32 years with endometrial hyperplasia without atypia on progesterone for 1 year. So as I told you, oral progesterone, you usually give it for 6 months. So in case she's on progesterone for so long, because there can be risks associated with it, like thromboembolism and all. So you shift these patients to LNG-IUS, if not completed family. In case she has completed family, you can also offer, since it has not regressed. Okay. Since after 1 year also on progesterone, it has not regressed, you can also offer her, it is you can give her an option of hysterectomy, total abdominal hysterectomy, bilateral salpingectomy, because she's premenopausal. Okay. So this was about it. Now coming over to atypical hyperplasia who wants fertility preservation. So first of all, in these patients, you have to counsel them that there is a high risk of progression. So as high as 27%. And you have to tell them there is 43% risk that if you do a surgery, there can be an occult cancer. Then you have to be very, very sure that there is no underlying cancer. For that, you have to do a hysteroscopy guided biopsy. Second thing, you have, because there is 4% risk of coexisting ovarian cancer, you have to do tumor markers, CA-125, and imaging, TVS and MRI to rule out any coexisting ovarian or endometrial cancer. Then, for fertility preservation in atypical hypoplasia, you have to involve the MDT. And you have to do a 3-monthly biopsy. One negative biopsy, you refer them for ART. And once their family is complete, you offer them hysterectomy with bilateral salpingectomy. And this is again an important thing. Suppose you've been doing 3-monthly biopsy and you fail to see regression by 1 year. Then you have to tell the patient, or there is any progression to the cancer, then you have to tell the patient that the risks involved are high. And you have to offer them to undergo hysterectomy. So this was about atypical hyperplasia. Then this question, I'll just give 30 seconds for you to write the answer for this question in the comment section. Okay, so she is, the answer here is option B. So I'll just repeat the question. She is 34-year nulliparous woman who's seen at menstrual disorders clinic for heavy menstrual bleeding. She has a PCOS and BMI is high. Histopathology shows crowded glands with back-to-back fashion, with minimal stroma, with cells involving big nucleus in the biopsy. Upon further discussion regarding the management, women express strong wish to retain her fertility. So this characteristic picture of glands being arranged back to back and minimal stroma, big nucleus, all these are atypical features. So, and she has endometrial hyperplasia with atypia, and she wants to retain fertility. So the best answer here will be aim to achieve disease regression in at least one endometrial biopsy sample before attempting to conceive. Okay, this is again an EMQ. These are the options. And this is the question. I'll just give you 1 minute to answer the question. I'll just read the question for you. So she's 48-year woman with irregular menstrual cycles, and an endometrial biopsy confirms endometrial hypoplasia without atypia. So there is endometrial hypoplasia without atypia. The woman has normal BMI, and only significant past medical history is that she has a history of laparoscopic sterilization at the age of 35. LNG-IUS was inserted for 6 months, after which it was removed. Endometrial biopsy at that time was normal, and subsequent biopsy again at 6 months was negative, and women continues to have ongoing bleeding. What is the most appropriate management? So what that means is she's symptomatic despite you have given her progesterone. We'll just give you 1 second to answer. Okay, so answer to this question, if you've gone through the option, is option I. That is, you have to offer hysterectomy for this patient because she's symptomatic despite progesterone therapy. Okay, now quickly, let's cover this algorithm. Although we have discussed all important points. So simple hyperplasia or hyperplasia without atypia. First of all, the best management, I told you, medical, LNG-IUS or oral progesterone. And then you have to do 6 monthly biopsy until 2 negative, BMI less than 35, more than equal to 35. You have to do, followed by 2 negative biopsy, 6 months apart, you have to do annual follow-up. In case atypical hyperplasia, ideal treatment is go for surgery. If it is premenopausal, it is total abdominal hysterectomy, bilateral salpingectomy. If it is postmenopausal, then with bilateral salpingophtectomy. Then you have to, suppose she wants to preserve her fertility or she doesn't want removal of the uterus. Then you have to do 3 monthly until 2 negative, followed by 6 to 12. And in case she wants to conceive immediately, then after any 1 negative biopsy, you refer her to the fertility clinic. So this was about it. Regression, I've told you, how do you follow up? In case it is persistent on your follow-up management. So if it is without atypia, endometrial hyperplasia without, then you start medical treatment if observations failed, and advise, because she's still symptomatic, you can advise THBSO if it is persistent after 12 months of medical treatment. Atypical, you directly advise THBS. In case there is progression, then you involve the MDT and accordingly manage. Atypical hyperplasia, you go for total abdominal hysterectomy, bilateral salpingo-oophorectomy. And if it is cancer, then refer to oncology clinic, involve MDT, and manage according to the staging in the protocol. So this was all about endometrial hyperplasia. Hope this was helpful. And in case you like this video, please press on the like button. Also, you can, in case you have any questions, you can write in the comment section, and do subscribe to the channel. Thank you so much.
Recording stopped.
Hello, am I audible?
Yes, ma'am.
Yeah, it is done. No, 30 minutes are over, right?
Yes, ma'am.
Okay.